Welcome to episode 85 of the RSM COVID-19 series. My name is Michael Marmot. I'm director of the Institute of Health Equity at UCL. And today we're going to be talking about inequalities. I recently wrote reviews of two books on the pandemic that had already come out. Michael Lewis's book, The Premonition, which I reviewed for The Lancet, about the pandemic in the United States, and Jeremy Farrar with Anjana Ahuja, his book, Spike, that was just published, which I wrote a review of for the Financial Times, the FT. And both books talk about management of the pandemic, absolutely vital. Neither really touches on the question of inequalities. And what occurred to me in reading these books and writing about them is that we need two strategies. One is control the pandemic. Then everybody would be much better off. But the other is the inequality dimension. And controlling the pandemic does not absolve us of the need and the moral responsibility to address inequalities. To discuss this question, we've got an absolutely brilliant panel. As I said to the panelists, I'm going to spend quite a lot of time giving you their full CVs. No, I won't. I'm going to tell you who they are, but we'll then talk about the topic. Joe Bibby is Director of Health at the Health Foundation, very much involved in these issues. Bola Owolabi is Head of Inequalities at NHS England. And Habib Naqvi is the Chief Executive of the NHS Race and Health Observatory. I can't imagine three better people to be discussing these issues. So let me just kick it off by asking, in order, Joe, Bola, and Habib, to describe what happened to health inequalities during the pandemic. What kind of evidence do we have? Joe, could I start with you?
Great, thank you. Well, last April, when the extent of the impact of the pandemic on all aspects of our lives became clear, the Health Foundation set out plans for our COVID impact inquiry, and we published those findings last month. And the report, I would say, is probably the most comprehensive analysis of the full extent of the pandemic to date. And working with an expert panel, which Michael, of course, you were part of, and chaired by Dame Claire Moriarty, what we set out to consider was who faced greatest harm and threat to life from COVID-19 itself and why? What were the wider health benefits and harms of the measures taken to suppress the virus? And what has been the impact of the pandemic on wider determinants of health, which may themselves cause harm to health in the future? And what we found in broad terms was that the factors that make people vulnerable to poor health in normal times place them at greater risk of harm during the pandemic. And if I was to sum up in one sentence, what I think we need to learn from the pandemic is that while medicine saves lives of many of us when we're ill, the pandemic was an accelerator of the wider factors that erode people's health on a daily basis. And the stat that I would draw out, which I think provides a kind of starkest example of this, was the level of mortality that we've seen in under 65s from COVID in England relative to other comparable countries. After Bulgaria, up until April this year, England had the highest level of deaths in the under 65 population. And the greatest burden of these deaths were among people who were poorer, who had poorer health in the first place, and who worked in sectors that offered fewer workplace protections. So for me, the lesson is that if we want the UK to improve in the national rankings of health outcomes, a first-class NHS is not enough. We need to tackle the root causes of poor health, poverty, poor quality work and housing, and the associated risks that these bring in terms of opportunities to be healthy. And it seems to me in this debate, there could be no stronger voice than those of you listening who have dealt with the consequences of poor social conditions on people's health on a daily basis, pandemic or no pandemic.
Thank you. Bola, evidence for inequalities during the pandemic.
Thank you, Sir Michael, and really important points there that Joe has made. I'll draw our attention to the key reports that have come out during the course of the pandemic. I start with the COVID disparities report from Public Health England, followed by the Beyond the Data report led by Professor Kevin Fenton. We've also seen the Health Foundation's The Same Pandemic Unequal Impacts report. And I think all of these put together can be distilled into the fact that we've had the same pandemic, but we've had disproportionate impact on three domains. One, the likelihood of contracting COVID-19. Secondly, the severity of disease. And finally, mortality. And across those three domains, we see a skewing towards the most deprived populations, as well as ethnic minority communities. And what that says to me is health inequalities are not new. We go back to the Black Report, Aitchison Report, indeed, the Marmot Report 2010, which was of course followed by the 10 years on review in 2020. All of them crystallizing the challenge of health inequalities. What the pandemic has done is to shine the stark light that we've all talked about on those pre-existing health inequalities and also exacerbated them. And what it says to me is we have an opportunity here, as I've said in a number of forums, drawing from the weight of evidence before us, that our biggest legacy from this pandemic necessarily must be narrowing health inequalities.
Thank you. Well, you've set it out. Habib, from your perspective, what's been the impact on inequalities?
Sure. Thank you, Michael. I guess there comes a tipping point in any society when the evidence becomes so irrefutable that the only way forward is with concerted action. And if I think back to where I was in March of last year, we knew that we were heading towards a very significant pandemic, which was going to have an adverse impact upon the most vulnerable in our society. We knew that when we look at domains of health inequalities, inclusion, equity, that those would probably go on to the back burner, because when you move from a working in the normal situation to working in an emergency situation, as we very quickly were, that's exactly what happened. But what I was very surprised about was how quickly those issues went on to the back burner. So, I mean, we cannot escape the very sad fact that, you know, there are over 130,000 deaths in the UK from COVID-19. But what we can do is learn lessons from the previous waves and make sure that we're well equipped to deal with the level of urgency to protect the most vulnerable within our societies. And we should be, you know, we should be on the front foot with that. We've got very robust legal frameworks. When we look at the Equality Act or we look at the Health Inequalities Duties, we've always had very good investment in healthcare research. And we've had a long history of migration in this country. So when you think about ethnicity and you think about ethnic health inequalities, we've got large and growing ethnic communities, and we should be on the front foot in putting things in place to not be kind of on the back foot when we face these kinds of emergencies. But it can be argued that at the same time, our responses in general to health inequalities, and particularly to ethnic health inequalities, have been in historically, somewhat confused, costly, and fragmented. And whereas specific units and institutions have been set up and have been doing wonderful work in some cases, in other cases, they have been focusing on surface level issues without, as Joe highlighted, looking at the reasons for the deep-rooted issues around some of these issues. And what we need to do is look at those deep-seated, deep-rooted issues in order to tackle the inequalities that we have across society. And doing much of the same will no longer suffice. We know that this is not just a reset moment for us, but it needs to be a total refresh moment for us, where health inequalities is absolutely in the forefront of leaders' minds going forward.
Thank you. Let me ask the panel, perhaps starting with you, Habib. Bola, in her introduction, said that COVID affected the most vulnerable, and she talked about deprivation and ethnic minorities. Personally, when we published the 10 years on, the Marmot Review 10 years on, in February 2020, we didn't say much about ethnic differences, largely because there weren't a lot of data. And I confidently predicted that socioeconomic inequalities in health would be amplified by the pandemic. I did not predict that ethnic inequalities would be amplified by the pandemic. So it took me by surprise. Did it take you by surprise? And was I wrong was I just plain ignorant?
I mean, the figures, the statistics that Bola referred to with regards to ethnicity did take us a little by surprise, I have to say, Sir Michael. But at the same time, we knew that we perhaps could have, as a society, as a healthcare system, perhaps done a lot more very early on in order for us to tackle those challenges that we saw very we saw very early on last year, because we know that a top-down, one-size-fits-all approach has perhaps derailed countless well-meaning initiatives and interventions to tackle health inequalities in the past, and doing much more of the same when it came to particularly the COVID vaccine program could and perhaps did to some extent at the beginning derail that particular program. So there was a level of, what is it that we need to do? And the word that comes to my mind very early on, came to my mind and still does, is the word trust. Because we know that trust is about truth, it's about amplifying that truth consistently over time. And we needed to increase the level of trust, to increase the level of confidence amongst our diverse communities. And once that started through the vaccination program, through the excellent work of the NHS, we began to see an increase in vaccine uptake amongst the ethnic minority communities in particular, because we were now utilizing more venues that were appropriate to ethnic minority communities. We were building the level of confidence by using mosques, black churches, synagogues, temples, as opposed to just focusing on conference centers and horse racing venues. So trust is absolutely essential. But it goes back to my point, Sir Michael, about being on the front foot as opposed to chasing our tail at an early stage.
Thank you. Bola, did you predict that this astonishing, heartrending excess of mortality of COVID-19 in Black African, Black Caribbean, Bangladeshi, Pakistani, and to a lesser extent Indian? Did you predict that before the pandemic? And regardless of whether you got it right in advance. What does it tell us? How should we be responding to it?
Thank you, Sir Michael. I think I will admit, like you, that the scale of the disparity in disease and in outcomes is not something that I predicted. But when you look at the Nuffield report on ethnicity coding, in retrospect, I suppose one shouldn't have been surprised in that the pandemic demonstrated that the limited availability of ethnicity data and the quality of the data did reduce understanding of ethnic health inequalities, and therefore the ability to accurately predict some of the outcomes in the way that you've just described, and indeed the ability to identify effective responses. And so I think our current challenges do range from the absence of ethnicity data from sources like the death registry, for example, the mortality statistics, the opportunities for us to improve ethnicity coding within our primary care data, and also the need for more up-to-date, which we will now have, the census data. So I suppose what I'm saying is our inability to predict what did transpire during the pandemic in relation to ethnic health inequalities was in large part due to the paucity of the data or the absence of the data. And where we did have the data, its quality. And so I think our opportunity now, which we've reflected within the NHS England operational planning guidance for 21-22, which was published on the 23rd of March, is one of our key priorities is to ensure that data sets are timely and complete, in particular, ethnicity coding. So those are my reflections on that point.
Thank you. Joe, let's move on a little bit. There's no question that lockdown, the societal response to the pandemic, had differential effects depending on people's occupation, housing, income, ethnicity. What should we have done, and what should we now be doing at the current state we're in terms of addressing these inequalities?
Yeah, thank you. So this is obviously a question we looked at in the inquiry. And I think the first thing we should all remember is that despite lockdown being very tough for a lot of people, it did save lives. And when we looked at the data, the biggest single factor explaining the high death toll we saw in the UK was the timing of lockdowns, which were later than they were in other countries. And also there was a factor that the UK is a highly connected country, both globally and within the country. So it allowed for faster and greater spread of the virus once it had entered the UK. So I think, lockdowns did save lives, and that obviously we shouldn't lose sight of it. But, clearly what we saw was that there were not sufficient protections for some groups in the context of lockdown. When we looked at the groups of people who were able to work from home, you saw much lower case rates and death rates, clearly, and the people who were not able to work from home were then also most likely to be people in occupations that had fewer protections, and not just the protections from the virus, but protections in terms of sick pay and so on. So there are huge disincentives for people to self-isolate, and that exacerbated the problem. I mean, we also identified mental health was clearly a big problem that emerged during the pandemic, and I suspect we'll live with the shadow of that for some time to come. and women in particular reporting increased levels of poor mental health relative to other people in the population during the lockdowns, and being left with that legacy. So I think, if I was to reflect, it wasn't so much that the lockdowns were the wrong thing to do, they were clearly the right thing to do, but did we put in place enough protections around the lockdowns? And then I think the other thing is actually it goes back to this question that this isn't just something that we should be concerned about in the context of a pandemic. Statutory sick pay is something that is really important for people's health in all times. And just, going back to the vaccination program as an example, we've seen some really innovative ways in which services have tried to reach people who have found it hard to access vaccines, like taking mobile vans out to workplaces where people aren't able to take time off work to access healthcare. Well, again, this is something we should be thinking about. This isn't just a problem in the pandemic. People not being able to take time off to access routine care for their long-term conditions, is something that is going to exacerbate inequalities throughout, time, not just, during a pandemic. So I think there's a lot to learn about the way in which we need to improve people's working protections to enable them both to take time off when they're ill and facilitate access to healthcare.
So we could have been more sensitive to the inequality issues. I mean, lockdown, of course, is a blunt tool. I was just looking again at a graph that the Financial Times published, which showed that the better a country controlled the pandemic, the smaller the economic hit. So that the voices against lockdown were saying, oh, we'll damage the economy. But the countries that controlled the pandemic will damage the economy to a much smaller extent than the countries that, like us, did it badly. We had the biggest hit. Let's think about coming out of the pandemic. The Prime Minister said 2 years ago, a year and a half ago, that his ambition was to level up. When, speaking personally, when on the 30th of June, we published our report, Build Back Fairer in Greater Manchester, I said this was a blueprint. If the Prime Minister is serious about levelling up, building back fairer, we've shown him what to do. I don't know what your reaction was when he made his big levelling up speech a couple of weeks ago. He said that a person in Glasgow or Blackpool has 10 years fewer on this planet than somebody living in Hertfordshire or in Rutland, and nobody knows why. Well, when people say to you, why do you do these reports if nobody takes any notice? The Prime Minister said, nobody knows why. And I thought, some of us think we know why. Do you know why? Let me do it in different order. Bola, what should we be doing? Do we know why those big inequalities exist pre-pandemic, exacerbated by the pandemic? And what should we be doing to build back fairer as we come out of the pandemic? Bola?
Thank you. So I will draw a quote from the Health Foundation's report in May 2020, Emerging Evidence on Health Inequalities and COVID-19. Quote, those hardest hit by the pandemic tend to be those already most disadvantaged. In the recovery phase, policy must also take a long-term view and consider the potentially lifelong impacts of the pandemic on children and young adults. I wanted to anchor my response in that very important statement, which again reinforces the disproportionate impact that we've already talked about. And of course, there are multiple reasons for the differences in life expectancy, healthy life expectancy, and disability-free life expectancy between populations. We know from a health point of view that there are challenges in relation to healthcare access, experience, and sometimes outcomes. More broadly, we also know that the causes of the causes, to use a Marmot phrase, have a significant impact, whether that is in terms of educational attainment, employment, household income, those wider determinants. So we understand from the evidence base what the reasons are. And I have described what I believe that the roles of the NHS are in tackling health inequalities, even as we move into the recovery phase. And I will outline those again as the contribution that the NHS can make. The NHS as a commissioner and provider of services is able to powerfully influence people's access, their experience, and their outcomes from the services we provide and commission. The NHS as an important partner within the integrated care system has an important contribution to make in working with local authorities, health and well-being boards, and the voluntary sector in addressing those wider determinants of health that are beyond the purview of healthcare in isolation. Thirdly, the role of the NHS as an anchor institution. The decisions we make in terms of the use of our estate, our procurement practices, our employment services and practices, those anchor institution functions are an important way that the NHS can impact on health inequalities. And finally, the role of the NHS as an employer. The 1.5 million people working in the NHS are a microcosm of the wider population. And as we make inroads in tackling health inequalities for our staff, we gain the credibility to be able to do the same for the wider population. So those are my reflections on the possible reasons why and what we in the NHS can do as we go into a recovery phase.
Thank you. Habib, I'm going to ask you what we should be doing as we come out. There've been some terrific questions in the Q&A, which we're not going to get to them all, but related to it, Alan Silman, hi Alan, has asked about health literacy. And one might say literacy more generally, but he says, what with R numbers, 7-day moving averages, antibody levels, different types of tests, etc. Is there an issue? He talks about health education or health literacy. I think I would broaden it. As we seek to level up, to build back fairer coming out of the pandemic, is there an issue of health literacy and literacy more generally that we need to address? Habib?
I think what we certainly benefited from through the pandemic was having real-time data to understand the diverse needs of our diverse communities. But this is, as Bola has highlighted, this is about looking at the causes of the causes. And it's a leadership issue for me. We need leadership on this agenda. We need people's moral compasses pointing in the right direction in order for us to close down the gap between the promise of our ideals as a society, as a forward-thinking society, and the reality of our time. And the reality of our time is a stratification that we see in terms of access, in terms of experience, in terms of outcomes with regards to health. And we need to make sure that we focus on that. And we have an opportunity when we talk about levelling up. We have an opportunity with the establishment of the integrated care systems across the NHS. It's an opportunity, but it's also a challenge as well, because we know that we need representation, diverse representation at senior leadership levels. And I hope as the NHS begins to recruit the leadership of these integrated care systems, that it can focus on increasing and having appropriate representation at all levels. But we cannot escape at the same time the stratification, the long-standing issues that we have in terms of kind of the racial stratification in health. And there are numerous examples at the NHS Race and Health Observatory that we are focusing on, not least looking at maternal health and looking at a range of issues. If I just pick one, endometriosis is one example where we need to really focus on and look at those causes of the causes. And when I talk about that, it is about looking at some of the racial biases that exist in clinician assumptions around pain management. When we look at a specific area, a racial bias in terms of the policies and the processes that have been in place for decades, racial bias in terms of the evidence upon which interventions, services, and medical devices are put together. And that goes back to education, it goes back to looking at research, it goes back to looking at clinical trials and representation within clinical trials, not just participation, but including people that lead those clinical trials. So if we begin to look at some of the causes of the causes, we will be better placed in terms of levelling up.
Thank you. So both Bola and Habib, coming from the health service perspective, nevertheless say we should be looking at the causes of the causes. Joe, let me come to you to talk more generally about the social determinants. The first question in the Q&A that I can see came from Philip Matthews, and he said, we've been talking about health inequalities since the Black Report. Are we going to be able to do anything about it?
Well, let's hope so, I guess has to be the answer. I think this is a really important thing to reflect on. Why is it that despite all the evidence, we haven't got the political traction and kind of the traction with the public? And I think there's two things from the Health Foundation point of view that we're trying to think about. First of all, really trying to frame the value of good health to society. I think a lot of the narrative gets dominated by the burden of ill health, the cost of ill health to the NHS, and kind of just reinforces poor health as being an NHS problem, as it were. And what we're interested in doing is looking at the value of good health to society and the economy, and seeing it as an investment good and something that by giving people good homes, a good start in life, a good education, good quality work to take part in, that doesn't just benefit them and their health, it benefits the wider society. And as an example, when you look at employment rates amongst people with or without health limiting conditions, employment rates for people with a health limiting condition is 47%, and for people without is 81%. So it just points to the big stark difference in terms of what it means for us as a country and our economy, whether we have people in good health or not. So I think really making this case of good health as a necessary asset to build the society we want is really important, and one that I think chimes with the levelling up agenda. I think the other side of this is that, we spend our days talking about, wider determinants of health. We probably spend some of our nights dreaming about them. But actually, what I'm always struck by is that this is not widely understood. And I'll just give one example that illustrated this for me, which is earlier this year, I was doing a similar sort of presentation like this. And then there was a question from the audience. And we were talking about economic development and how good economic development can create the conditions for healthy lives. And there was a question from the audience. So this is an informed member of the public, as it were, who has joined a conference like this. And they said, how is it that poverty can make people ill? Because people were saying this. How can poverty make you ill when the NHS is free? And I thought this is such an important question to hold on to. This just tells us so much about how people understand their health and management of their health and illness. And we do have a free NHS. We have a wonderful NHS and it's all there for us when we need it. And it's so important. But in a sense, I think people come to look to that as the answer to good health. And that's why there's such an important challenge for us all to think about how do we really communicate in a way that makes sense to the public, the wider determinants of health, because I think we really have to own the fact that as yet, we haven't done that.
Thank you. I mean, let me give my own response to, we've been discussing inequality since the Black Report, and to say three things. First, that health for the most disadvantaged in society, the Black Report was 1980, health for the most disadvantaged has improved dramatically. So that's one criterion of success. What it means to be poor in terms of health is much better now than it was when the Black Report happened 40 years earlier, whether we're looking at infant mortality, at life expectancy. I mean, it's dramatic. The worst off group now in Britain has an infant mortality of 5 per 1,000 live births. That's more than double the best off group, so that's terrible, but 5. You remember when Mrs. Thatcher got all upset because the infant mortality went up from 9.1 to 9.2 for the average? The best off group has got half the average of when Mrs. Thatcher was Prime Minister. So health's improved enormously for the most deprived groups in society. Secondly, health inequalities get bigger and smaller. And Ben Barr's analyses from Liverpool suggest that the gap in life expectancy between the poorest 20% of local authorities and the rest got narrower during the New Labour period and got wider again in the decade from 2010 on. So the poorest can get healthier and health inequalities can get bigger and smaller. So they're not fixed. And the third thing is that we documented in our 10 years on report that we did with the Health Foundation, that life expectancy for the poorest 10% outside London went down in the decade from 2010. That's really shocking. So I said the poorest can get healthier, and they did. But in the last decade, they got less healthy. So the answer is yes, the evidence shows that these are not fixed. There's a great deal that can be done. It's just not being done. And we think we have the evidence. And as Joe said eloquently, it's not confined to the healthcare system. I want to, building on from that, I want to come back and ask, starting with Bola and then Joe and Habib, there doesn't seem to have been much interest at national government level in addressing these issues, but there's a huge amount of interest at city level, local level, regional level, huge amount of interest. And integrated care systems that you mentioned, Bola, they are by their nature regional, local, city, they're not national. How much can cities, regions, localities do, as it were, despite the national government? And how much do they need the national government to come in behind them? Can I start with you, Bola?
Thank you, Sir Michael. I think the integrated care systems are our great opportunity to really move the dial on health inequalities in the right direction. And I will refer to the 4 purposes of an ICS set out within the government's white paper. And I've often said you could distill those 4 purposes of an ICS and crystallize them into a single sentence, which is to narrow health inequalities. Also, when you look at the second reading of the bill, there are within that references to the role of the ICS in relation to the health inequalities of the population, whether that is in terms of access or outcomes. Against that backdrop, what ICSs can usefully do are a number of things: a clarity of purpose, ability to focus their energies, to instill a sense of hope, and to have collective ownership. So if I begin with the clarity of purpose element, I think there is sometimes a danger that systems may focus on the analysis of health inequalities and forget to clarify their purpose. And so I have been advocating and will advocate again that ICSs should consider, as they draw up their governance, infrastructure, structures, and framework, anchor all of that in the 4 purposes of the ICS and be explicit about their role as the part of the system that is ultimately responsible for narrowing health inequalities, in particular the ICS partnership. The second is focus. Because health inequalities are complex and wide-ranging in their causation, sometimes people can be paralyzed by the analysis of it. And I think if people can narrow down what they're seeking to do to a number of tangibles and galvanize the energy and the focus of the system behind those tangibles and take an incremental approach that is a multi-year approach, I think that would be very helpful. I think it's also important to instill a sense of hope. ICSs do well to look at the vaccination program and inquire deeply into what did we do differently? What did we do differently that means we've had different and better outcomes than we've had hitherto on other areas? Because people do need a sense of hope that it can be done in order for them to remain engaged in the discourse. And so I think ICSs can very much draw hope from the success that we've had in the vaccination program. And that is not to say that we should be complacent. And finally, collective ownership. There's something about the leadership, the governance of the ICS that needs to anchor the need for collective ownership of this endeavor within the fabric of the ICS and how it operates. So that would be my thoughts in terms of what the ICS can do to really make the most of this, what feels like a once in a lifetime opportunity to really make a difference.
Thank you. I'm sure the ICSs can be very important, but I want to ask, as it were, the next question, which is, given the importance of early child development, preschool, education, housing, food, having enough money to live on, communities, all of those things which are outside what the ICSs are set up to do, how can we build on what the ICSs are doing to get local action right across all the different important domains? And is that possible without the funding from central government? Habib, what's your thought on that?
I think that ICSs are certainly a step forward in the right direction. We know that when we look specifically at the most vulnerable, when we look at specifically at ethnic minority groups and our diverse communities, that racial inequality is a global system-wide issue that requires a global and system-wide response. So for me, ICSs are certainly a step in the right direction because, as I said before, a kind of one-size-fits-all top-down approach can derail well-meaning, perhaps, interventions. So we need a more of a joined-up approach to this. And when we look at the old NHS, as it was, I guess, we know that it is perhaps the most visible expression of a social contract between people. But to be proud of our society and to be proud of our healthcare system, we cannot be blind to some of its imperfections. And so moving towards having more integration, moving towards joining up, more of a joining up approach between health and social care, health and local authority, bringing in more of a bottom-up approach to tackle some of the issues that we have across society at local level is absolutely the way forward. That's not, Sir Michael, that's not to say that this is the solution and its mission accomplished, but it is certainly a direction, kind of a movement in the right direction going forward.
Michael Doyle in the Q&A has said perhaps the focus on ethnic inequalities draws attention away from the fundamental causes of material and social deprivation. What's your thought about that, Habib?
It would, I guess it would draw attention away only if you want to if you're in the space of allowing it to draw attention away. As I mentioned before, we need to focus on the causes of the causes, and what we are doing within the NHS Race and Health Observatory are three things. Firstly, catalyzing and facilitating high quality research evidence and rapid review, so looking at the data and the evidence. Secondly, turning that into actionable recommendations for policy change. And thirdly, supporting the system, the healthcare system and wider society to implement those policies on the ground. And that's not about, looking at or not looking at specific issues, but it's about looking at, as we've all mentioned, I guess, before, looking at the causes of the causes. And if we can do that, as we are beginning to do that through the NHS Race and Health Observatory, then we will be in a better place in focusing on or pulling the trigger on those things that need, or will have a positive impact upon people's lives at local level.
Thank you. Joe, Katrina Delagi, in one of the questions submitted in advance, asked about digital tools. And I get asked this question a lot, and I never know what to say. Tell me what to say. What role do digital tools play? Could they play? I mean, do they play in generating health inequalities, and could they play in reducing health inequalities? How could we use digital tools in a better way?
Yeah, well, interestingly, the Health Foundation, gosh, it must have been about 12 or 13 years ago, we funded what was at the time labelled one of our innovation projects. And the innovation was to do Skype-based consultations for people with diabetes. And we spent a lot of time supporting this work and trying to encourage wider uptake and so on. And then suddenly a pandemic arrives and everything moves sort of virtually overnight online. And it just does show that, kind of getting spread of innovation can be kind of very quixotic in terms of the things that influence. But so I think it's an interesting one to consider. And the Health Foundation has published some work looking at what is it we need to learn from the way in which we moved to a more digital-based service during the pandemic. What should we hold on to, but what do we need to be aware of? And I think, it certainly will cut both ways. Going back to the sort of comments I was making earlier about what we know are some of the practical barriers people face to accessing healthcare, when they're in working environments that don't allow time off. Digital is a way in which it facilitates people to access care from a range of settings. And so for some people, I'm sure it will make a difference. But we did look in the COVID impact inquiry at some of the challenges around digital exclusion. And we've done a report that we'll be publishing shortly with the Good Things Foundation on digital exclusion. And of course, it's all the things we know about with other aspects of people's lives. It's the cost of data. It's whether people have the right connectivity to be able to make use of these services. It's whether people have the digital literacy to be able to navigate a more digital world. So I think it certainly will open up, and it has opened up access in ways that many people have been trying to achieve for some time. Yet, I think we need to recognise that it could reinforce some of the existing inequalities that we have, for different reasons perhaps, but that we have with face-to-face services.
Maybe I can start with you again, Joe, while you're there, as it were, and go backwards. One of the things that really struck me in our Manchester work, dealing with David Gregson, who started this program on child well-being in Manchester, Be Well. The figures from UNICEF are that for 15-year-olds in the UK, we rank 27th out of 38 countries on child well-being. We're not even average, we're below average. And that's 15-year-olds. And the reason I said, Joe, perhaps start with you, because you talked about mental health during the pandemic. Now that 27th out of 38 was pre-pandemic. That's only likely to have got worse. How do we prioritize, particularly adolescents, in this question as we come out of the pandemic? What do we need to be doing?
Yeah, I mean, I think, this is a classic kind of complex problem, and there isn't going to be one solution. But I think one of the first things is probably recognising the importance of that age group. We have for some time, I think, recognised the importance of early years, first 1,000 days and so on, often overlook teenage years and that transition into adulthood. So I think kind of the fact that people are paying more attention to this is clearly important. We've done work looking at what is it that gives young people the kind of building blocks for a healthy transition into adulthood. And we found it kind of boils down to four things. One is good emotional support, and that could be from families or it could be from sort of wider networks. It's also about having the right personal connections. So the people who can provide some of that softer support and guidance, helping young people build skills and confidence, things that youth services often classically do, but sadly have been very badly cut back. Skills and qualifications are clearly important. And then the final thing is a financial safety net, which came out. And I think this is possibly one of the biggest of sort of stark differences between a lot of young people that we're starting to recognise now is the difference between those young people who have the benefit of a sort of wider financial safety net from family and those that don't. So I think this is, we need to be looking at this holistically. We need to be thinking about how we build the right assets for, in young people as they develop. But clearly there is going to be some immediate needs in terms of how we invest better in mental health service provision, because there is an acute need there at the moment which isn't being met.
Thank you. We're just about at the end now. Bola, you've been a model of clarity about your vision for ICSs. In 1 minute, is there anything you want to add as we depart?
Thank you, Sir Michael. Going back to focus, I think the 5 priorities that we set out in the NHS is actually applicable across the board, and I will leave us with thoughts around those 5. First is to restore our services inclusively. And regardless of the sector, I think that is a collective ambition we can all own. The second is to mitigate against digital exclusion, building on the exchange that you've just had there with Joe. The third is to make sure that our data sets are timely and that they're complete, especially ethnicity recording, as we've talked about. To accelerate preventative action, whether that is in health or in social care or in education. Again, I think this has a multi-agency application. Finally, we talked about prioritizing leadership and accountability. I think if every sector can look at what these 5 key priorities mean for that section and that sector, then that would be a very powerful way of collectively moving forward on this agenda in a way that crosses organizational and sector divides.
Great, thank you. Habib, you've got 60 seconds.
60 seconds, Sir Michael. So my key message would be that we have a choice. We can either be passive bystanders to this agenda, or we can be active agents for social change and to tackle the inequalities that we have within society. But to do that, we need to ensure that inequalities are addressed, not just by words that we have here today, for example, but by deeds and by actions. And that, for me, is about leadership. So we need to show leadership on this agenda. And like I mentioned before, we need to have our moral compass pointing in the right direction.
Thank you so much. The bad side of chairing this panel is that we only have an hour. I'd love to have kept this going all afternoon. The good side, it's been an absolute privilege to be here with Habib, with Bola, and with Joe. Thank you all so much, just terrific. The weekly episodes from the RSM won't be here next week. There'll be a short break over the summer. The next episode will be on Thursday, the 19th of August, a monthly panel chaired by Sir Simon Wesley. And then on Wednesday, September 22nd, there will be an extended episode looking at vaccines, the variants and infection moving into the winter. I think it'll probably be the only time that RSM has had someone who has a Barbie doll modeled on her, Professor Sarah Gilbert and Professor Sharon Peacock. Thank you all who tuned in, and special thanks to the panel. Goodbye.